All right, we're going to talk about airway management today, and we'll hopefully get through the military medicine lecture as well. This one's a little long, so we'll see how it goes. We'll start with a little check on learning here. So you got a 21-year-old dude that's brought into the ED, crashed his motorcycle into a telephone pole, pretty standard. Vital signs, BP 85 or 52, heart rate 125, 97.2, respirators 26. So what do you think? Stable, unstable?
Unstable.
Unstable, right? Yeah, that's probably not good. Primary survey, he's got ecchymosis to his right abdomen. Airways secure, does not have any evidence of bleeding. Externally, receiving 2 units of blood products through a rapid infuser BCF13, fully exposed. What's the most appropriate next step?
B.
Yeah, so we completed the primary survey yet. I mean, by what it's telling us a little bit, we've got like A, B, C, D. He's exposed, so yeah. The only one on there that's on the primary survey is going to be our EFAST. So if we stabilize him, yeah, he might get, pan scan imaging. Probably not though. If what do you think this guy needs? I know we haven't done that lecture yet, but yeah, he needs blood. But he probably needs a surgeon, right? Probably needs his belly opened up. He's bleeding somewhere, and we don't think it's the chest. He's got that ecchymosis on his abdomen. Good. Yeah. All right. 20-year-old female. Brought up with diffuse abdominal pain. Fell off her horse. Like I work at a country. What's up? Oh, it's turned off. Ah. My bad. Is it plugged in? Is the power on? Yeah. All right. So 20-year-old female, brought in, fell off her horse, diffuse abdominal pain. I say this a lot because I work out in the country by my house, and a lot of people fall off horses. Airways pain, complains of sharp left shoulder pain with deep breathing. She was given IV fluids by EMS. Initial physical exam has tenderness over the epigastrium, noted left abdominal bruising, not having obvious external bleeding. Breast sounds are equal bilaterally. Pelvis is stable. Vital signs are blood pressure 78 over 45, heart rate 135, respirators 20, 99% of room air. What's the most appropriate next step?
Blood.
Blood, right? Yeah. So, yeah, obviously, she's hypotensive, tachycardic, definitely unstable. CTs, she's not stable enough for that. I think it says her breath sounds are equal bilaterally, so probably doesn't need a chest tube. Airways pain, so we don't need to secure that yet. Pelvis is stable, so blood products makes the most sense. Let's do one more. 31-year-old female sustains blunt trauma to her abdomen and arrives by ambulance to a small rural ED, continues to complain of diffuse abdominal pain, and is peritoneal on exam. Primary survey was completed, resuscitation was initiated with blood. Patient's current vital signs are blood pressure 100/55, heart rate 116, respirators 18, O2 99 on 2 liters. We don't have a trauma surgeon at that facility or operating room. What's the most appropriate next step? She definitely needs to go somewhere with a surgeon, right? What are we doing next?
A.
What makes the most sense? Yeah, alpha makes the most sense. So, complete secondary survey, continue resus with blood, and transfer to a trauma center. Really, stabilize and transfer on this one. We don't want to spend the extra time without a surgeon getting CT scans or labs or anything like that before we're transferring, unless they're, completely stable and we're not suspecting any sort of surgical need. Cool. All right, there's our reference. So we'll talk about different, some of it we'll go through a little bit quickly, because we've talked about like non-invasive management with airways or what our interventions are. And mostly we'll focus on RSI today. We'll cover some of those basic airway adjuncts that we have, and then we'll talk about like our 7 Ps of, really 6 Ps, but for intubation or rapid sequence intubation. So here's our like warm-up case. Yeah, she does not look good. So 46-year-old female presents to the ED, EMS with burns to her chest, neck, and face, sustained burns during a flash fire while deep frying turkey. Vital signs, 134/86, heart rate 122, respiratory 27, 98.6 temp, 93% on room air. So this, we'll talk about how we're going to manage this, but this patient probably needs our airway secured earlier rather than later, just because the edema that's going to be secondary to that burn. All right. So we have two different ways we kind of classify these. We got like non-invasive airway management technique. Then we have invasive or like definitive airways, which would be our endotracheal tube or endotracheal innovation, cricothyroidotomy, tracheostomy, and then there is a thing called transcutaneous needle jet ventilation, which that's something really for special populations like the pediatrics or really little kids. We talked about type 1 and type 2 respiratory failure, but one's got hypoxia without hypercapnia, and then one's got hypoxia with hypercapnia. So we classify these just because certain pathology will present with one or the other, usually COPD for type 2, and then or other causes for type 1. All right. So the first thing, we're checking when these trauma patients come in is do they have an airway? So, we have different maneuvers we can do, like our jaw thrust or head tilt, chin lift. Make sure we have that airway open. If they're unconscious, we need to check for any sort of obstruction, like foreign bodies. Do they have any trauma to the face? And then we want to predict, and we'll talk about some of the ways we can predict, like what's going to be a difficult airway and how we would prepare for that. All right, so first thing we do is optimize the patient position. So we like to call it the sniffing position. If you can kind of see how his head is a little bit forward, we like to have that ear aligned with the sternum there. And it's, I guess if you're like sniffing a flower or something like that, that's the sniffing position, not like sniffing a line. You're leaning a little bit more forward. But we can put a towel under there. We also can do what we call ramping them, and we can place something under the shoulders to help with some of that as well. But we'll start with our non-invasive management. So we have our nasal cannula, simple face mask. We have our high flow nasal cannulas as well. And we have non-rebreathers, and we'll kind of show some pictures. But all of those deliver a different amount of oxygen. So, and we kind of judge where what patient needs which one. So we start with like a nasal cannula. You can get 2 6 liters. And we got a simple face mask, and then our non-rebreather, which is normally like 10 up to 15 liters a minute. All right, so here's our list of equipment for non-invasive airway management. I'm not going to get into this. It hopefully makes sense. Like you obviously need the equipment, you need oxygen source, you need tubing. When we're talking about airway management, it's the old like 1 is none, 2 is 1. You want to make sure you have backups for everything. You want to make sure your equipment works. Like normally in the ER, and you guys will probably be one of the people responsible for it. Normally it's one of the like first year residents. Sometimes I'll have you do it, but we inventory all of our airway equipment at the beginning of every shift. And so we have checklists, and we go through all of these supplies that they're there, and if not, we have to restock them. So you guys will learn how to have the proper equipment. It's also very important, like I can speak for the Army, like when you're in a Roll 1A station, you're given most of this equipment, but it's like in your little med chest somewhere. None of it's put together, so it's important you guys actually train your medics to, if you have an ET tube, you want to make sure you have stylets with it. If you have like your BVM and all of your airway equipment, you want to make sure you have oxygen and that tanks are actually filled and they're useful. You want to make sure you turn them on and check them before every shift or whenever you're out in the field or deployed. I know it sounds silly, but you'd be surprised at how often you don't have the appropriate equipment that's actually together for your airway stuff. So we have our BVM. It's got that self-insufflating bag on it. It can deliver quite a bit of oxygen. You can obviously breathe for the patient with it, but you can also place it over them like a face mask as well with oxygen coming through it, so it's useful for that as well. And then we have our nasopharyngeal airway. I was going to ask if somebody wanted to demonstrate it, but I figured something happened and somebody would complain or something. Yeah, I get in trouble. Like you can't do NPAs in the middle of class, but they're very minimally invasive. So this is something easy. You know, sometimes if we're concerned for any, you know, they still have an airway, but it might be tenuous. Maybe we need something we can place to the NPAs in there. Our OPA, not as commonly used because the patient has to be comatose, obtunded, or they don't have a gag reflex, but this is something we can utilize. And you'll see it probably more often used in phase 2, like with anesthesia on those rotations. If they have, you know, a patient still retains their respiratory drive, but they're like heavily sedated, they may place one of these in there. And then we have our like supraglottic or extraglottic airways. So these aren't placed into the trachea. It's like above the glottis, hence supraglottis above it. So the common one we use is like an eye gel, which is the one on the left there. They're similar to like the old LMAs. They used to have to inflate that little cuff, and it kind of goes in the back of the throat. I think they're replacing the eye gels, but those are commonly in our medical equipment sets. The one on the right is called the King LT. So this one is, I think we have a better picture. It'll come up later, and we'll talk about how we use that one a little bit more. But that one actually, normally it goes into the esophagus. You inflate the two different balloons, and then it occludes both portions so that it goes into the trachea. And then here's our non-invasive ventilation. So we got our CPAP and our BiPAP. The BiPAP, you know, delivers a little bit higher pressure when you breathe in, and then the CPAP kind of delivers the same amount of pressure at all times. The BiPAP makes it a little bit easier to breathe for the patient, so we usually prefer BiPAP. Some patients that utilize a CPAP at home are very comfortable on it, so we'll sometimes use a CPAP as well if we need that non-invasive ventilation. You know, we do have to make sure the patient's, you know, not altered in any way. They can cooperate with us. And then we want to make sure that we don't have any concerns that they might aspirate anything. So we have to make, you know, if they have nausea or vomiting, this is something we don't want to use at that point because we worry about the risk of aspiration. All right, so the reason we like to use it, it reduces that work of breathing in these patients. You can see it like improves cardiac function. So there's a lot of great reasons to use this. This lecture, we're really going to focus more on our rapid sequence intubation techniques. So I won't get into it too much because we covered it during the respiratory lectures, but most common uses, you know, we may see it in like heart failure, pulmonary edema, and COPD are probably the two most common ones we use these in right now. Maybe like asthma exacerbations next after those first two. And then there are some other indications on there. You can really try it on any patient that you're concerned or that you might think you need to secure an airway. We can try this first. And then here's some of the complications. So somebody that has a beard or some odd shaped face, or I can't remember the term, but there's like people that have no chin. I used to have a meadow that had no chin and it was funky looking. So some of those patients, it doesn't work well on them. Any aspiration risk, like I said, we want to avoid these. All right, and then here's more of our supraglottic or extraglottic airway. It's nice because they can be above the glottis. We don't have to get a definitive airway. So we only want to use these for short periods. This is something more pre-hospital realm that they might use if they're unable to intubate or they don't need to intubate. They work well for a short period of time until you can secure a definitive airway. So there's that eye gel. It's soft. It has gel in there versus air. And then you don't have to use your laryngoscope or anything like that. Not a lot of complications with it. You know, they may get a sore throat from it. I haven't seen anybody get a laryngospasm from supraglottic airway, but it is possible. All right, so there's our LMA, which looks kind of like the eye gel, and that's what we used to most commonly use for our supraglottics, and it has a little cuff you have to inflate. More often you see the eye gels now. And really, it's just something placed in the back of the throat. You can kind of see on the anatomy there. It occludes the air from kind of leaking through, and it goes into the trachea, but we don't have to actually place a definitive airway deeper in there. And then here's our King LT. So this one, like I said, it usually ends up in the esophagus, single lumen, and then you flow up the two balloons, and that forces the air into the trachea. You know, there are pretty large cuffs on those, so they, you know, we can cause some issues with afterwards when we place these. So because of the high cuff pressure, you'll have a lot of pain and complications, but hopefully the patient survives, which is the good part. All right, this is what we're really focusing on, is going to be these invasive airway management, or what we like to call definitive airways. So, like when you read questions, if it's talking about a definitive airway, that it's going to be one of these. So, a crash intubation. This is when this is what we prefer not to do, but sometimes we have to. So, this is when we don't use any medication, and this is, you know, the reason it's you know, less preferred is because usually the patient has pretty high mortality rate if they have, you know, if they're unconscious, unresponsive, no gag reflex. You know, a lot of times portends a poor outcome. And then the other question is, like, how long have they been apneic or without air? And then here's what we're going to focus on. So rapid sequence intubation. So this is what we like to call our systematic approach to securing an airway. It still is considered, you know, emergent. This is why we talk about it and we practice it a lot, so that we actually can perform it rapidly without, you know, causing too much apnea or hypoxia on that patient. So what we do, you know, what we like to do with this is we like to sedate the patient and then we paralyze them. And the reason we use these different steps is shown to, you know, improve first-time pass rates, and it's also shown to improve or reduce the risk of hypoxia. And we'll talk about some of the, like, hemoglobin and oxygen dissociation curves and how long you can go without oxygenation before we have a very difficult time getting them back. All right. So what are our indications? They can't oxygenate, they can't ventilate, so we need to look at securing that airway. Sometimes we'll do it like if we suspect that they're going to lose the airway, like if they have anaphylactic shock, they start to get, you know, airway edema, or we see any angioedema. This is something we might do prior to impending airway compromise. So facial burns as well is something we want to consider. If we expect long transports, like if we're going to fly a patient for a couple hours, this is something we want to consider prior to that transport, so that nobody has to deal with it while they're in the back of an ambulance or on a chopper. And you guys already know, any GCS less than 8, we need to intubate, or GCS 8 or less, we need to intubate. All right, not a lot of contraindications. So this is usually the only means we can use to secure that airway, which would be an endotracheal tube or cricothyrotomy, or like more in the hospital realm, tracheostomy, which we're not doing typically in the emergent setting. But we also want to consider, before we do it, what's our chance of securing this airway? And we'll talk about our Lemon score, which is how we kind of characterize whether we think it's going to be a difficult airway or not. But it's important that we have all of our equipment and our backup equipment ready to go, and always have a cric kit. I always like to have one because I think it wards off bad spirits. You know, if I have it, then hopefully I don't need it. And, you know, it's worked 98% of the time so far. All right. So like it says, you know, first time attempt rate, and the percentages vary, not super important, but pretty, you know, 1 to 3% overall attempts fail with standard techniques. That's why we need to have our backup equipment. Usually we want the most experienced person to be securing that airway, which begs the question, like, how do you learn that if it's always the most experienced? But First time I intubated was I was like a private brand new medic in Iraq, and the ER doc went to intubate, and he like saw me, and he's like, "Oh, here, you take it." And I was like, "I ain't never done this before." It worked out well. That's why we train, and we'll practice this. It'll hopefully make more sense on our lab. I think next week? This week? I think next week. We have a lab where we have some airway mannequins, and we're going to practice all these techniques, so you get a little bit of training in it. But, you know, our endotracheal tubotracheal intubation is the cornerstone of emergency airway management. So we all need to be proficient in it. It's something you may not do very often, especially, you know, in a battalion, role 1 or role 2, but it is something we need to be ready for. So that's why we practice. And, you know, sometimes maybe the only training you'll get before your real life situation is on a mannequin. So try to take it as seriously as you can. But like it says, you know, we're putting a tube directly into the trachea so that we can, you know, verify that we have, you know, a definitive airway in there. It aids in oxygenation, ventilation, helps with aspiration. And then we do need to have some sort of sedation and paralysis for it to work most appropriately in the right patient. But here's our 7 Ps. So we want to, you know, preparation is key. So like I said, get all your equipment ready. You know, 1 is none, you know, 2 is 1. So we want to have multiple endotracheal tube sizes. We want to have all our, make sure we have oxygen that actually works. We have BVMs. If we have a ventilator there, we have all the appropriate equipment set up for it. We have suctions, backup suctions. Next, we pre-oxygenate. And then pre-treatment, we kind of omit from it. There's not a lot of cases where we're going to use pre-treatment. There's a couple indications, but they're still kind of questionable, so we're not going to worry about that one too much. And then we want paralysis with induction, so we want to give them some sort of sedative first, and then we paralyze, and then protection, positioning, placement of the tube, and proof, and then post-intubation management. All right. So like I said, preparation is key, and this is something you guys need to think about when you're in charge and you're, you know, running an aid station or role 1 or even role 2. You want to make sure you have an actual RSI kit set up. So there's something you guys are going to have to make. It doesn't come in your equipment set, but you need to have the right medications in there. And normally it's a sedative and a paralytic agent. Typically we have them pre-drawn and ready to go in our RSI kits, especially in the ER. So we have a little box and you know, the meds are in there ready to go. And we have a few different kinds in there, which we'll talk about the different kinds of paralytics and sedatives we like to use most commonly. All right. So here's our equipment list. I'm not going to go over everything in there. During our lab, we'll cover what equipment you need for these, and it'll make more sense when you actually have to utilize them. All right. So you want to make sure when you're intubating, you want to have them on a monitor. You want to make sure you're monitoring their heart rate the whole time, their blood pressure, oxygen saturation. We need to have some sort of end tidal capnography on hand, whether that might be just a little color changing device, or ideally we would like to have end tidal waveform on our machines. And then we need IV access. So here's, you know, a nice picture of how it looks when you're intubating. You guys see anything wrong with this? The guy's like 12 feet tall and he's raised to bed. So, you know, you don't really want to be sitting up that high. And he has a direct laryngoscope too. So he's not on video, you can get away with this, but you know, maybe he can see it well. I guess I'm not him intubating, but I would probably raise the bed a little bit more, which is all part of your preparation. So once again, make sure you got an oxygen source. You need to have a BVM in case you're having to bag that patient. You should have your OPA and NPA, 2 suctions, and then your primary and backup equipment. So like I said, you got your like laryngoscope, so you have your video laryngoscope, your direct laryngoscope. Then you got a backup cricothyroidotomy kit in case you have to convert to that. Important things, testing the cuffs on your ET tubes. You'd be surprised, some of them don't hold air in them, so it's important you check those before you do any sort of airway procedures. And then you want to have like supraglottic airways for backup. And then it's helpful to know the patient's weight because we're going to have to look at ventilator settings after we secure that airway. And then here are some factors that are going to affect your intubation. So any obese patients can be a little bit more difficult airway. If they have a lot of facial hair, you're not going to get a great mask seal if you're having to bag valve mask them. Anybody with dentures can be difficult. You know, if they have a history of sleep apnea, short neck, limited neck mobility. Those are other considerations. Then we got to consider facial trauma, angioedema, anybody that we suspect any infectious causes like that could cause like Ludwig's angina can obstruct the airway. So we need to consider all these during our airway assessment. So we can, you know, we like to get a Mallampati score if we can beforehand. So we're looking really at, can we see the pillars? What's our view of the uvula on there? And really, how large is our tongue, and is it obstructing any of these features? So we have class 1 through 4. I mean, class 1 and 2, usually, you know, you can hopefully, you can rest assured, like maybe it's a less difficult airway. Any like 3 or 4 you want to consider, maybe this is going to be a difficult airway. And then here's our Lemon score. So really, we're looking externally at their body habitus, their head and neck anatomy. We have our evaluate, so the 3-3-2 rule is really you should be able to fit 2 or 3 fingers in their mouth. You should be able to get 3 fingers between the mentum and the hyoid bone, and then 2 fingers from the hyoid to the thyroid. Typically, that's going to be your most ideal situation. You guys don't need to know this. I know it's not on your slide. I just put it on there because it's it explains it and gives some pictures that are a little better on there. And then we want to look for any signs of obstruction. So, you know, do I suspect any like masses, tumors, any Ludwig's, any edema? So these are going to be considerations that could obstruct that airway, and we need to think about it. And then neck mobility. So are there concerns we can't get the patient in a sniffing position or the appropriate position, like, you know, maybe they have a seat collar on, so it may make it a little bit difficult. So these are all considerations for our airway assessment prior to intubation and whether we think it's going to be a difficult airway or not. All right, so here's our 2 different blades we use for our laryngoscopes. So one is a straight blade, which is Miller, and then one is a curved blade. You'll get you'll get practice on the mannequins of both of them. Some prefer a Miller, some prefer a Mac blade. It's mostly what you were trained in initially is what you're the most comfortable with. But one of them is placed in the vallecula, and it indirectly lifts up that epiglottis, and then the other one you have to physically lift it up with a straight blade. So those are like the 2 big differences depending on which one you're using and why. A lot of times, like we use most commonly like Millers in kids and Macs in adults, but it's all preference. Some people use a Miller for everything. Anesthesia uses a lot of Miller blades, so that's where a lot of people are first trained in. Anybody intubated? Is that how you guys were trained? Most people, yeah. Like when you train with anesthesia first, a lot of Miller is used. But now we use video laryngoscopy, so it's a hyperangulated blade, so you don't really get a choice at that point. Once you learn it, it's super easy. It's just like it's almost like a video game. You got like a little joystick. You're just watching on the screen, and then you just twist your tube a little bit to get the position to get it in the trachea. And here we have different sizes of ET tubes. We have cuffed versus uncuffed. We'll cover the Broslow bag during our lab, but that's a pediatric bag that is color and height and weight based where we measure on the patient. And then it'll tell us which tubes we use, but really like the small infants will use uncuffed. Most patients we use cuffed tubes after that. So most common size, you can get away with a 7.5 probably in most adults. So it's a very common one to have ready on standby or in your airway kits. Usually like 8 in adult males and 7.5 Adult females are very common. The two most common sizes you're going to use. Important equipment is going to be your stylet, so it's going to be a rigid, malleable device so you can angle it correctly. We usually place those in there and we call it like, it looks like a hockey stick when we're actually intubating, so you'll see that during the lab and how we actually angle our ET tube so that we can get we have a better chance of success for securing that airway. Then you make sure you have a syringe with it so you can inflate that cuff, check your cuff before. And then you need to have something to hold that ET tube, like some 1-inch tape, ET tube holders. You can use IV tubing as well to secure it, but you need to have all that prepared beforehand. All right, so pre-oxygenation. So this is something we need to begin immediately. If we have any inclination we're going to intubate, we need to start pre-oxygenating these patients. So it's important to remember we need to administer that 100% oxygen outlet for at least 3 minutes beforehand for our pre-oxygenation, or you can use a vital capacity breaths, or what the appropriate pre-oxygenation time frame is. You can use a non-rebreather mask, which delivers quite a bit of oxygen, so that one's going to deliver like 60-70%, and then the BVM can deliver a little bit higher oxygen. So like I said, we can place that base mask over them with the BVM and deliver oxygen that way as well. And then here's our time to hemoglobin desaturation. So if your initial oxygenation is 0.87, which, I mean, really we're looking at here at 100% SpO2. So if you can see, like a normal healthy patient, they got about 8 minutes before they start to desaturate below 90%. And then the more sick they are, the less time you're going to have. So 8 minutes is really that cutoff point. We're likely not going to get them back over 90% after that. So that's what we try to avoid when we're intubating. I mean, the less time they're hypoxic, the more ideal outcome you're likely going to have. And then pre-treatment, this one I said we omit from most of our RSI algorithms, but it is something to consider. The evidence behind it, even pre-treating, is not great. So it's something we don't do very often, but we can consider in the right patient. A lot of times we'll wait for that response before we start using it, just because a lot of those medications have significant side effects with it, which is why we omit this step. All right, so the important part is going to be our sedation, or what we call induction, and then we do paralysis. So, it's poor form if you paralyze the patient first, because they can remember everything, but they can't move. It's a pretty scary situation according to people that have had it done to them, which is why we like to use these, our stepwise fashion here, so we can do the right thing during RSI. But common sedatives are ketamine, etomidate, and sometimes propofol are going to be our main sedative agents we use. In the Army's medical equipment sets, it comes with etomidate, which is still a great medication, and you can use it. Ketamine's a controlled substance, so it's something you guys have to plan for. If you're going to the field or deploying, you want to make sure you've ordered ketamine and you have it on hand first if you're going to be utilizing it. And then we have our paralytics, and the three we use are going to be succinylcholine, rocuronium, and vecuronium. And we'll talk about the differences between those paralytics. Some have a longer half-life, so you get a longer time for paralysis, which can be great unless you have a difficult airway, and then it takes a lot of wear off, and you're having to sit there bagging them manually for a long period of time. All right. So here's our three most common sedatives or induction agents. So we have etomidate, which is a great medication. It can decrease your intracranial pressure, intraocular pressure, really neutral on blood pressure. There's always been arguments in emergency medicine, like whether ketamine is the best versus etomidate. The latest study actually had, I think it was looking at blood pressure. They were looking at mortality outcome. first attempt pass rates, and actually etomidate was better, and even with blood pressure, it was a better agent as well. So it kind of caught some of us by surprise because a lot of us were always ketamine people, and we're like, ketamine's best for everything. But etomidate is like probably a little bit better, or at least equally as efficacious. Propofol, you know, our issue with it, especially in the emergent situation, is that we run the risk of decreasing their blood pressure, causing hypotension. So it's something we want to be careful with. It can cause apnea, which is probably what killed Michael Jackson when he was abusing propofol. Nice thing is it is an antiemetic and an anticonvulsant, so certain patients we consider it in, especially our epileptics, if we're having to intubate them. And then ketamine is usually the most common you see used right now. It's probably the most common one I've used is ketamine, just because in the military we've been using it for a long time. And that, you know, it's great, especially for like your asthmatic patients or somebody who needs that bronchodilatory support. Our issue with it is it increases your secretions. It does help with blood pressure, so if somebody's hypotensive, it's a great choice to use as well. We do have to consider that like emergence phenomenon when some people can kind of wake up dissociated and kind of angry. So something we need to consider prior to using that ketamine. And really, I mean, if we're intubating them, they're not usually waking up in the ER, so we don't worry about it too much at that point. But, you know, you don't need to know like dosing for your test, but it is something to always remember. Common dosings are like, you'll hear, like I like to use 100 and 100, so it'll be 100 of ketamine and 100 of succinylcholine, or you can use 100 of rock too. So we try to keep it simple. All right. So after we sedate that patient or induce them, so they have that like dissociation or no memory, hopefully, of the event, we want to then paralyze them so that they're not fighting us. We don't want that gag reflex. And it'll facilitate our intubation. We do have to consider maintaining sedation during the paralysis. So if it's taking us a while to get ready for it, we need to consider either redosing our sedative prior to ending paralysis. And then here's our common one. So we got rocuronium, vecuronium, and succinylcholine. Succinylcholine's been around for a very long time, but we have like depolarizing and non-depolarizing agents. So one of them can be reversed and one of them can't. So succinylcholine, once you give it, you're going to have paralysis. You don't have any way to reverse it. However, it is the shortest acting on there, which is why we like to use it. And it's probably been around a very long time. So we have our newer ones, rocuronium and vecuronium, and they're longer acting. So you're looking 30 to 45 minutes for both these of paralysis. So that can be kind of concerning if you have a difficult airway. But we still very commonly use rocuronium. Rocuronium is probably most common because I think vecuronium has to be mixed, if I remember right. It comes in a powder, so we don't use it as commonly. And then we want to look, you know, so they have side effects, but not really too many side effects for rock and vec. Succinylcholine has, you know, rarely we worry. I think we have it on the next slide. Oh yeah, there it is. So here's some of our like complications or contraindications that we need to think about for succinylcholine. And really the big ones we want to consider like any hyperkalemia, any sort of recent trauma, so burns and crush injury, can be starting as early as like 3 days after the injury. We worry about causing some sort of arrhythmia or having side effects from succinylcholine, so we try to avoid it in those situations. The good news is usually they were just injured in the ER, so it's not something we have to worry about too often unless we have a patient transferred to us. And then one of the concerns is that malignant hyperthermia, which I think, wasn't that on your last test? Yes. Yeah, so yeah, it's very low risk, but it is one of the medications that's probably more commonly associated with malignant hyperthermia, so we want to consider that beforehand. Obviously, we don't know what patient's going to have that unless they were randomly intubated before with succinylcholine, they tell you that. We also worry about, like they can have that massive or spasm, but one of the nice things about suctional coding is how fast it works. So it has a really rapid onset time. And then the patient kind of fasciculates and kind of shakes once it works. So you can watch them and you're like, all right, we're good to go. Whereas the other ones, you kind of have to wait a minute or two until they're paralyzed and you're kind of watching and checking. All right, so positioning, we want that sniffing position. Sometimes we'll place pads under the shoulder. We call it ramping the patient to give us the correct angle that we want. We want, that ear aligned with the sternal notch. And then if we fail multiple attempts or the initial attempt, we need to reposition that patient and verify that we have them in an ideal position for intubation. Once again, here's that sniffing position. So you can, elevate the ox book, put a towel under there. We have, you can, sometimes it can be difficult with a seat collar, so that's why we'll ramp patients to avoid it, or we'll change our bed, what height the bed is, what angle the back of the bed is. All right, so placement with proof. This is important. So we want to have some sort of device on standby. Initially, we'll have our colorimetric changing device for our end tidal, just to verify that we get a color change and that we're not in the esophagus or in the belly. And we need to make sure that we have the tube lubricated prior to. That can be helpful. And then we need to suction out anything that can obstruct our view in there. And then, like it says, if you're not sure, just take it back out so you can appropriately place it. But the best way to confirm is going to be direct visualization of it going through the vocal cords and into the trachea. So nothing is better than that. The gold standard for monitoring is going to be our continuous waveform capnography, so our end tidal CO2. And then we want to listen or auscultate the chest, so we can listen for any sort of, bilateral auscultation, and then we can listen to the belly as well to see if we hear any air going in there. And then condensation in the tube is helpful, but it doesn't, it's not definitive. If they're improving on their oxygen level, that's great. That's another good sign. Then we want to get a chest X-ray afterwards just to confirm placement, make sure we're not like a right main stem intubation. You can use ultrasound for it, not very commonly used. All right, there's your view. So that's what you should see. You should see that tube pass right through there, right through the vocal cords and into the trachea. Yep, there's your two different places. So you got your esophagus and your trachea, so you don't want to go in the esophagus. And then there's our confirmation. So the top, you have that colorimetric change, so it should turn it should change colors on there to verify that you're getting end tidal CO2. And then we have our monitor, so we want our end tidal capnography. We look at the waveforms on there, and then clear regular waveforms or the CO2 over 30 correlates with proper ET2 placement. So you can confirm with ultrasound. It's not something we teach, but there are places that will utilize this. And I'm not going to really get into it. All right, post-intubation management. So if we did our preparation appropriately, we have a ventilator there ready to go. The picture on there is the SAVE 2 ventilator, which comes in the medical equipment sets. They're replacing them right now with a new one that they said they're going to send us a bunch to use or train with during labs, but this is the common vent you have, and there's basic ventilator settings. Typically, respiratory rate 10 to 12. Tidal volume, we use like lung protective strategy, so usually 6 mLs per kilogram. Assist control is the ventilator setting we use most commonly. We usually start at 5 and titrate up, and then we titrate the oxygen to the O2 or over 94. So that's something we start with a higher FiO2, and then we decrease it and adjust it to avoid oxygen toxicity. And keep your patients sedated if they're on the ventilator. Inpatient in the ICUs and the wards, we're obviously going to wean them off ventilators, but we're not covering that in the ER. We don't we rarely take anybody off the ventilator in the ER after we secure their airway. And then there's other options, which we won't get into very much. There's your nasotracheal intubation, digital intubation. Digital intubation doesn't work very well. Transillumination, I've never seen these. We have some pictures of them. I've never seen like the transillumination method. I've seen the other ones or utilize some of the other ones. And then complications, so putting the tube in the wrong areas, pretty large complication. That's what we try to avoid with some of these steps on here. So making sure we visualize that tube going through the vocal cords is going to be our best. You can get tube displaced, so this is very common if you're going to be moving those patients, especially in like a military setting, and when you're transporting on litters. The litter isn't very wide, so you tend to run into too much equipment on it, displacing or dislodging that tube. You're going to look for ET cuff leaks. So they actually have little machines that the respiratory therapists will have, a respiratory tech, and they can place a little device on that that'll tell you the pressure of that cuff, so you can check it without having it deflate or anything like that. And then a retinoid cartilage avulsion, very rare, but something that is possible. And then there's always complications of perforation when you're working in that area, so you want to be careful. All right, here's what a digital intubation looks like. The first very poor method, not a great success rate in it. Here's our nasotracheal intubation. So this, in the right patient or in a more controlled environment, you'll sometimes see this used. He's still utilizing a video laryngoscopy scope to verify that that it goes through those vocal cords still. So he's still confirming placement the same. I've never seen this. I don't know where they use it at, but maybe somebody does. It sounds cool, but then you're in like a dark room while you're managing a very sick patient. So I don't know. And then these ones are alternate airway management. So these ones have little scopes on them. And then you place your tube over that little, you're basically an optical stylet, so you can look through it and visualize that you're going in the correct area. Not very commonly used in the emergency department. I've never seen it used in the emergency department, actually. And then here's our video laryngoscopy. So this is going to be our preferred technique. And this is going to be the most common you're going to see in the hospital setting. We have some that we're going to practice with during our labs. So most common ones are like the Glide Scope, or the other brands like your CMAC, which is the bottom one. So the two on the left are the most common you're going to use. They're hyperangulated blades. They work really well. The other ones on the right are like more portable ones. You don't see those very often. All right. So we always want to consider that difficult airway or those failed airways. So we consider 3 unsuccessful attempts by an experienced person. So after that, we need to consider our like secondary and tertiary plans of, do we need to do a cryo thyroidotomy on this patient, or do we need to find another means for securing that airway? Or sometimes we can just continue to bag them. Bagging the patient tends to work well if it's done correctly. And then let's take a 10-minute break. Be back at 9. All right, we're going to move on to talk about what sort of mechanical ventilatory support we have and the different ventilator methods. And really, we'll talk about the one we use the most often, which is assist control. This is our preferred in patients with respiratory distress. So assist control provides really guaranteed minute ventilation in these patients, so we can control the tidal volume, and we can control the pressure that we're going to be giving these patients, and the machine is breathing for those patients with every breath, so we can ensure that we have the appropriate respiratory support they need. The other continuous is really the same thing as assist, or it's essentially the same thing as assist control. It's giving that patient whatever our preset parameters are, gives that patient one breath with the appropriate volume and pressure that we programmed into the machine. SIMV is something that if the patient is spontaneously breathing, they can utilize. And if they're not getting the appropriate number of breaths, it has a predetermined one that it can also use. This one is not as commonly used, especially in the emergency department. And patients find it like quite uncomfortable too. So if the patient's breathing at a faster rate, it's giving them a certain amount of breaths a minute, and then they're breathing on top of that, so it can kind of worsen or affect that increased work of breathing that they already have. And then here's our ventilatory support parameters. So we usually like to use 6 to 8 mils per kg. That's going to be our lung protective strategy used for almost everybody. And this just avoids any sort of like barrel trauma on those patients. This is the ARDSNet protocol as well, so you commonly hear that term. We typically, 10 to 12 is common. You can do 10 to 20 breaths a minute. And really you're kind of basing that on the patient's saturation. We usually start at a PEEPA 5 and work our way up, and then we start with a higher FiO2, and then we titrate it down to keep their oxygen saturation, usually like over 94 to 96, around there. We rarely ever extubate anybody in the ED. And now let's talk about surgical airways. So this is going to be our cricothyroidotomy. So this is going to be another definitive airway, but it's going to be a more emergent procedure. We make an incision through the skin and the cricothyroid membrane, and we can place that tube directly into the trachea if we cannot secure the airway by any other means. It can look barbaric when you do it, but it's something we practice, so in case we need to do it, we can complete it successfully, and it should be done quickly. Here are some indications that we want to use it. Obviously, if their face it looks like a horror film and their face is completely blown off, we might not be able to get a tube in there, so we need to consider a surgical airway at that point. If you failed intubation those 3 times, you want to consider this. And then you can't oxygenate ventilate. All right. So it's nice because it can be done very quickly and easily. Have you guys ever seen those videos of like somebody doing it with a pen and a pocket knife and something like that? So it can be done with minimal equipment. We like to have kits already ready to go and set up. So this is something you want to consider too, having these in your airway kits. And making sure the appropriate equipment's there. You got little stylets if you need them, the appropriate tools to secure it. Like it comes with hooks, and we'll show some of the equipment here in just a second. But it can be done relatively quickly. Really, the only big contraindications are children less than 12. Obviously, if they're like missing that portion of their neck, it may be difficult. Unless you can see right in the trachea, that might be easier. I don't know. But yeah, any penetrating injury to that area, you may want to avoid this. Here's our landmarks for it. So you have, your Adam's apple with your thyroid prominence, and then that's the top of the thyroid cartilage superior to it, and then you kind of go below, and then you feel to the cricoid cartilage, that little notch there, and then in between that you have your cricothyroid membrane, and that's where you're making the incision. And we start with that. We want to do a vertical incision. We don't want a horizontal cutting across, just because you could hit some other structures in there. There's what a common cric kit looks like, the H&H. So it has a smaller tube in it. It has your syringe, scalpel, cric hook, and hemostats. If you don't have that, you can use a regular ET tube if you need to. So you don't actually need a kit. You can use a regular ET tube as long as you have a scalpel and usually some hemostats. You can make it work. And you may not even need hemostats. We'll practice it during our labs, and we'll perform it on our live tissue model as well, so you'll get a little practice with it. But it's usually a 4-step sequence. Palpate, incise, pull some traction, insert that tube in there. Sometimes you can use a bougie first, so it's all going to be your technique and how you learn and what you prefer. All right. Do we have a check on learning? Oh, we do. All right. 37-year-old male presents to the ED after motor vehicle collision. He's unresponsive, regular respirations, heart rate 58, blood pressure 90/60, SpO2 76. Which of the following is the most appropriate initial intervention? So pretty easy, I hope everybody. Just talking about airway, right? Yeah, so we're going to do immediate endotracheal intubation. Good. So let's think about this, because I see this commonly missed on EMED and surgery tests for our trauma block. So let's say this patient has a head injury. You know, you're worried about, some sort of subdural, epidural, or some sort of brain bleed in there. You're still going to choose airway. I don't know why everybody says determine the Glasgow coma skill. maybe because they think, well, if it has to be 8 for us to intubate. Well, no, if they don't have, secure air, you're starting at A, and if you don't have an airway, then you need to secure that first. So don't determine their GCS until you intubate. Now, if the question gives you the GCS and less than 8, you need to intubate. And there's where you need the tube. That's where the tube goes. Yeah, like it says, you still cannot breathe through your stomach. All right, we're going to move into the military medicine lecture. All right, so we're going to cover, our TC3 military medicine guidelines here. And we'll talk about care under fire and tactical field care, combat casualty evacuation. We'll look at some of the roles of care and what we consider different facilities, based on kind of the NATO standard. All right. Yep, we're going to talk about triage, what we use for pain control, antibiotics, or our combat pill packs. And I'm sure some of you guys can teach this better than me, but I don't want to hear it. I'm just not going to accept it. I'm kidding. You guys can watch this video on your own for time purposes today. And really it just covers, I just don't think they do a great job in it, but it is, I feel like I can do a better job, right? You guys can watch it on your own time. It goes under it shows the care under fire phase. And what's great is it's at the TCMC course, which hopefully all you guys will, or most of you guys will have a chance to go to and attend the TCM. Has anybody been to it already? Yeah, it's a great course. It's here on Fort Sam. For the Army enlisted folks, they usually do it during Bullock, which is nice. So it's supposed to be done prior to any deployment for providers, but it's a great course. All right, so combat medicine's a little different, obviously because somebody's trying to kill you. So we need to think about that first before we provide any treatment. But your tactics are going to be the large thing to consider. Hostile fire, it could be dark outside, you're going to be really amped up. So it's good to train in stressful situations, carrying all your gear, because what you'll notice a lot of times in those high stress environments, you might have your hands a little shakier than normal. So that's why we like to train and practice this. And then you got to worry about different environmental extremes and where you're going to be practicing at. Is it like blast versus penetrating injury or both? You also have to think about you don't have a lot of equipment, so you're going to have a limited supply. Hopefully, as the PA, hopefully you're not providing that frontline care, but you might. I mean, certainly there are times. I've definitely done it as a PA, so there are times you will. So it is something to consider. And the other thing about our military medicine slide, this is something that's not on your pants. There will be a couple questions on your test, but it's not something on the pants. So we just like to give you guys an overview because you're going to be the one in charge of your TC3 program in your unit. So here's our levels of care. So role 1 is going to be where most Army PAs start out at, usually in a battalion. And that's going to be your aid station or your self-aid buddy aid on the front line, providing usually the first care that a patient's going to receive at the point of injury. Then you move up, and you have your role 2, which is usually at a brigade level, and this will be your BSB or your area support medical company. Sometimes it'll be augmented with a forward surgical team, and we call it a role 2+. Sometimes in that situation, usually what the role 2 adds is they have a dentist, they have limited X-ray capability, they have a lab, which is really just an iStat machine. So I don't know how they call it a lab, because we can run an iStat. No offense to lab people, but yeah, not much more. You'll have one nurse, and then you'll have usually
1 to 2 doctors and a PA at these, so a little bit more support. You also have a shrink there as well. And then you have a patient hold capability to roll 2, so that it's usually, I don't remember how many beds, 12 or 24 or something. You can hold somebody for 72 hours there. And then roll 3 is going to be your, used to be called combat sport hospitals, I think they call them field hospitals now. This is going to be full surgical care. So this will be, most of them are similar to what like a level 1 trauma center is in the US. So you have your surgeons, you have your specialists like your neurosurgeons there at most of these. And these ones can provide more definitive care for that patient. They won't hold them for long periods, but it'll complete care until they can be evacuated back to the States. And then your roll 4s, usually definitive care at a theater, and they have all rehab and tertiary care capabilities. And then roll 5 are hospitals in the US. All right. So your equipment's going to be typically for TC3 is going to be whatever you can carry in your aid bag. So we won't get into like an aid bag packing class, but it is something very important. I think those in here who are medical have probably packed and repacked their aid bag 7,000 times. And the more experienced you are, the more stuff you just throw out of it. You're like, yep, don't need that anymore, don't need that. But it is something important to consider. Really, you're looking at basic equipment. So I need something to stop bleeding, a couple different dressings in there for like our trauma dressings, tourniquets. I need something for their airway, so we're looking at, usually not an endotracheal tube, but having like a surgical crike. And then one of your other devices like iGels, I guess King LT, I don't know if anybody still carries those, but usually not as commonly. Some people will carry an endotracheal tube, but one of the considerations for airway is, are you going to sit there bagging this patient in that combat environment? So those are things we want to consider with that. And then you have to carry a BVM, if you're going to worry about those airway issues. They have smaller ones that like fold up now, but still something you have to consider when you're looking at military medicine, a tactical scenario. 9-line medevac request card. Okay, yeah, probably have one of those if you plan on calling up a 9-line. Usually there's somebody else that can hopefully do that for you. All right, and then we talked about the MIST report for the EMS earlier. This is something that we use as part of like a NATO standard. So on top of our 9-line, we use a MIST report so that they can get the mechanism of injury, what injuries they have, what symptoms and vital signs, what treatments already done. And a lot of times they can launch with just the MIST report instead of going through your entire 9-line. And MIST report and obviously location and the first 5 lines on there. I'm not going to talk about the 9-line. All right, here's our 3 objectives. So we want to treat the casualty, we want to prevent additional casualties, and then complete the mission. So this is something more in a combat setting, so not really PA school specific, but this is something our medics are certainly trained really well in, and it's really kind of based on the mission set and what the commander's guidance is. But this is like a standardized pre-hospital guideline. I think they update it every year or 2, and it'll give you some great guidelines on what sort of interventions that are out now that they recommend, and hopefully it can be something that's stocked in your guys' medical equipment sets for using out there on the battlefield. But TC3 was designed to prevent those leading causes of preventable death. So I think they say like 90% of the casualties are going to live or die no matter what you do, and then there's that 10% that have some sort of preventable cause that we can affect. And so that's what we're really focusing on here. And those are typically like your extremity hemorrhage or junctional hemorrhage, loss of an airway, tension or hemopneumothorax, and then like our lethal triad on there, the hypothermia, coagulopathy. So we organize this into 3 different phases. So we have our care under fire, which is very minimal care. So really just a tourniquet and really getting that casualty out of the line of fire. Then we have our tactical field care, which is more of like our primary, secondary surveys and doing all of our interventions and more thorough treatment. And then we have our casualty evacuation phase. things. And we'll get into what these different ones are. So care under fire is usually self-aid or buddy aid, typically done by the first responder or whoever's on the scene. And really, it's when you're like actively being engaged, somebody's shooting at you, and the first priority is going to be obviously tactical fire superiority. So, you know, you're going to want to return fire. You don't know where it's coming from, just like shooting the direction everybody else is shooting. And then what you're going to do during this phase is really just what we call a hasty tourniquet. So we just a really quick tourniquet. We're not sitting there like, is it 2 inches above the wound? Am I 2 inches above the joint? You're really just placing the tourniquet as high as you can on the extremity, and you're pulling them out of the line of fire. Really, hemorrhage control is the only thing you should be doing, and that's with the tourniquet at this point, unless you want to get shot. All right, and here's what we do. High and tight tourniquet, so a hasty tourniquet over the clothing as high up as possible. And those are our two most common, our cat and our soft T tourniquets. Hopefully you guys have all utilized the cat before. If not, we'll use them during our labs and kind of practice a little bit with them. You'd be surprised at how poorly people can place a cat tourniquet. So we had these, they have different, I can't remember the name of the mannequin, but we have fancy mannequins that bleed. It'll tell you how much pressure that's applying. I mean, still not the best. You know, a patient, you know, an actual human's obviously going to be the best to train on. But we had these mannequins when I was a JPA. I took them out during our training exercise and just showed up at the aid stations. And I would say like 70% of the medics couldn't place tourniquet appropriately to stop bleeding. It's kind of sad. So it is something we need to practice. Go back to the basics, how to put a tourniquet on, and we'll train you on it during our labs to help you out a little bit. And the common complications or reasons why you would fail at placing it. I think everybody's issued a CAT, so then you'll have both these in your medical equipment. So it just depends on your preference which one you like. I mean, I think they both work really well, so it'll be whatever one you're trained on and used to using. I would focus on the CAT because everybody carries one. If you're more specialized, you may have different ones on there. I don't know what generation of CAT tourniquet we're on now. Like we're on like this 8, 7. I don't know. I did actually on I think it was like 05 maybe. The first generation cats, I actually snapped the windlass and like almost lacerated my hand one time, placing it on a casualty's thigh. They fixed that, luckily. All right, so once we move them out of the line of fire, and we're in a little bit. I mean, I'm not saying a safe environment, but the gunfire is not hitting you directly at this point. You got something in between you and it. Then you're going to move into tactical field care. So you're no longer under effect of fire. And this is when you do your primary survey. And it's a little bit abbreviated or a little bit different algorithm or mnemonic than you would use for like your A, B, C, D, E. So this one we use MARCH, so massive hemorrhage. Any massive hemorrhage, we want to place tourniquet on there. We want to stop any junctional bleeding if we can. Then we move into our airway. Do I have, does the patient have a hidden airway? Do I need to secure that airway at this point with, whatever means, whether that's like a supraglottic, whether it's King LT, whether it's a surgical Crike. We need to secure that airway, and then we move into respiration. So really, do I have any penetrating injury to that thorax? Do I need occlusive dressing? Do I suspect tension in my thorax? Do I need to put a needle into that patient? Normally something, I'm sure some people will carry chest tubes out there, but that's usually a little bit more specialized. Your average medic is not going to be carrying chest tubes. So usually it's some sort of occlusive dressing and a needle for needle chest decompression. Move on to circulation. So we have limited, blood products out there on the battlefield. Only certain units carry them right now, and it's usually soft. So you won't have blood, but you'll likely have some sort of other fluids, which we'll talk about here in the next slide. And then we have our hypothermia prevention. So you have your HPMKs or hypothermia management kits. You have your space blankets. So you want to have something there that you can prevent that hypothermia in those casualties. You can see like a space blanket there on this casualty. So massive hemorrhage. If we've placed tourniquet under our care under fire, we need to reassess that intervention. Very common, you're dragging people, moving them, even with the most well-placed tourniquet, sometimes they come loose, or at least that's what the flight medic had said to me before, and I'm like, no, it didn't come with. I don't know what you're talking about. So once you get them in a safe environment or under tight filter, you want to reassess those tourniquets. You can add a second tourniquet if you're not getting appropriate control on there, which you can kind of see in the picture. He's got 2 tourniquets on there where the arrows are pointing, so you can, they call it like a kissing tourniquet. You want to be careful that you're not having, the reason they say kissing is they need to be touching because you don't want to cause any compartment syndrome in that patient. And then we want to pack those junctional bleeds with some sort of hemostatic agent like Combat Gauze. And we'll practice that on our live tissue model, and hopefully you'll understand how to use, perform that in an appropriate way to get hemorrhage control, so it's not just shoving the bandages or the hemostatic agent in there. You have to do it in a sequential fashion if it's not that big. But really what we're checking here, like for vitals in this phase, is like radial pulse, and what kind of blood pressure does that equate to normally? Yeah, like 80, right? Good. Then you do a rapid blood sweep. Here's our 2 common airway devices that you usually carry, that medics will carry in an A-bag. So that's going to be your eye gel and then your surgical cripe. There's an MPA as well. Sorry, I should have mentioned that. So you'll have an MPA as well, and I think everybody has those in their IVAC kits too. So those are going to be your main airway control mechanisms when you're in the field. So not, the only definitive one you really have is that surgical cripe. Then we move on to respiration. So really, you're checking for any sort of tension with thorax, or like if they have any sort of sucking chest wound. So you're going to place one of those occlusive dressings on there. I don't remember which one's in the IFAC. It might be the Halo. Usually they have one in the IFAC. Every person does that's usually out there in the field or deployed. So you're going to place that over any sort of penetrating injury, and then you're going to assess for tension pneumo, and you'll place a needle if you need to. All right. So, and that's like I just said, we're going to practice these on our mannequins as well, so hopefully it makes more sense. But you have that 14 gauge, 3 1/4 inch needle. I think they even have longer ones now out there, but that's going to be the main mechanism you're going to use for those tension pneumothorax. And we used to, historically, it was second intercostal space, maculavicular line. I think TC3 recommends now more at the 5th intercostal space at the anterior axillary line. And they've done some studies. We did one too a while back on how successful medics are in placing these. So it is something you guys are going to need to train, especially your older medics. They're not trained on the 5th intercostal space, anterior axillary, so something to think about once you're in your units. There's our long giant needle or dart, whatever you want to call it. But that's typically what you'll have in IVACs or in your A-bags. And then circulation. So IV access, some people will have those little kits with them, like you practice with in the IV lab. I usually like to make my own kits, but something to think about during your TC3, or if you have an aid bag. Like I like, and I'm sure some nurses will get mad at me in here. You can't open all your stuff, but I usually open my IV bag and I open all of my equipment, place it in the IV bag, and then tape's already pre-staged on it, everything's open. What you'll find out is when you're really amped up in an environment like this, you can't even open regular equipment sometimes with all those little packages. So I like to have it pre-staged, everything's open, ready to go. So preparation is key for this. Really, you're going to have most commonly your crystalloids. There are other options out there. Some units will have usually 2 units of blood with them, or sometimes on missions you will. And then there are some older ones we'll talk about real quick, but we don't really use Hextend or head of starch anymore. Some people have like plasma light. There's some other, what other ones we carry out there? Yeah, so mostly your crystalloids or some sort of fluid, LR. And then we want to make sure we have TXA, so you're giving 2 grams of TXA during this phase of their care. You know, a lot of us will carry IOs out there as well if you can't get an IV, so you have, is there a picture? Oh yeah, I've got a picture, yeah, perfect. So you can get IO acts as well. So you're typically not carrying the IO drill out there. You don't need the drill to actually use your easy IO equipment, but it is helpful. But we also have our Fast 1 devices, which is a sternal IO, and that one really has a little package of, you can place the sticker on there at the sternal notch and you just aim for the location. And that one works by, all of those needles have to have the same pressure on them, so you have to have the correct angle for it to work, and then you're applying like a downward pressure with your weight and it just kind of shoots into that. It doesn't really shoot, but the other needles are tracked and then you insert that intraosseous needle. It looks very barbaric, it works great. We used to actually train and practice them on each other a long time ago. And then they made some policy like you couldn't deploy if you had one in whatever 6 months, but it used to be very common to practice on each other too. It really doesn't hurt that bad until you push some fluids through it. All right, and then here's our TXA. So we got lots of studies now showing the benefits of TXA, and we're trying to prevent that, you know, traumatic coagulopathy. So 2 grams of TXA given within the first 90 minutes is the most efficacious. 3 hours, I think, is the guideline. But they still study it all the time. Or the more recent study just came out I want to say this year or late last year, of 2 grams in the first 90 minutes had the lowest complication mortality rate associated with it, or most benefit, I should say. And then other things like especially if you're given blood or fluids, you might want to carry some calcium, but that's not very common out there unless you have, you know, a larger number of units. And then there's our fluid of choice. So if we could get whole blood, great. That's what we want to do. You will also have programs hopefully established in your units, which you'll have blood donors already identified that are your universal donor, and we'll check titers before deployment, so you know who can actually give blood if you need to do a trick like a battlefield transfusion or anything like that. And there's our HEDA starch or Hexten. They used to use it as a volume expander. Did not have a lot of great data behind it, but we used it for a while. But here's the preference of what we'd like to use. So whole blood's going to be the best. It's going to be the most balanced to what the normal physiology is. And then we move into our 1:1:1 ratio, or what we call balanced transfusion. And then, you know, 1:1, so PRBC is plasma. And then if we just have plasma, and then, or just PRBCs, and then LR plasma line. All right, so what for circulation, like our endpoint is, do they have a radial pulse or not? We also want to look at their mental status. So if they're still mentating and talking to us, that's a good sign as well. We typically, for these ones, we do we allow what we call like permissive hypotension. So we keep that systolic for when we're talking about like extremity hemorrhage or massive bleeding. In the trauma patient, we want to keep it above 80. Ideally like 90, but we call it permissive hypotension because what we're worried about is having too much pressure or diluting their blood, and then we're losing those clots that they're having, and they can continue to bleed out. If it's a traumatic brain injury, then we want to shoot for over 110 for their blood pressure, which we'll talk about during our TBI block. And then we have, other medications we can give as well. So normally just an anti-nausea medication, pain med or antibiotic are the common ones you're going to be carrying on the battlefield. And then our hypothermia, head injury management. So really, we want to make sure every casualty has some sort of space blanket on them or something covering them to prevent that hypothermia. And then we want to consider, our TBI or head injuries. So things we can do to help decrease intracranial pressure, we can elevate the head of that bed to 30 degrees. And then we want to maintain their SATs appropriately. So the blood pressure over 110 is preferred. No hypoxia. those increase mortality significantly if they are hypoxic at any time or hypotensive, which we'll cover during our TBI lecture. And then secondary survey after you've completed your MARCH or your primary assessment for all those preventable causes of death that you can readily fix. And then we want to move into our casualty evacuation. Here are some of those space blankets. So you got like your common one there on the left, and then you have like a more fancier kit on the right. It's just a little larger and harder to carry with you. But those are the two you'll probably most commonly see out there. Pain control. So this is going to be up to you guys of what sort of protocol you want to have. And the other consideration is you're going to be the one in charge of it for your unit. So you're going to be the one deciding what your medics are going to carry out there for pain control. And I think most commonly is like some sort of ketamine, Versed for pain control, and then usually some sort of anti-nausea medication like your Zofran or ondansetron are going to be your most common. Anybody carried these meds before, or what did you guys carry? Ketamine and Versed. Yeah, pretty common. Do you carry any other ones for, like IV ones for pain? Nah. Yeah. Fentanyl. Yeah, fentanyl used to be a lot more common. Lollipops, not as much anymore. So this is something, if you know, we talk about combat pill packs and we talk about combat pain medicine, but none of these kits are made for you. So if you want your medics to carry them, you guys have to make them yourself. So you have to decide. It's also a controlled substance, so you're the only one that's, and your name is going to be on the controlled substance register that will only issue it to you. So it's important you guys have some sort of proper training for your medics and documentation that you've trained them, because when it goes south, it's going to be your license they're looking at. So it is something, you know, you want to take seriously if you're doing it, and having your medics carry ketamine or any other controlled substance. All right, so our antibiotics, usually all combat wounds are dirty. So, you know, you're in a dirty environment, you have blast injuries, you never know what they're going to put into whatever bomb they're using. Like I've had casualties where it was like forks and spoons were in the patient. I was like, metal forks and spoons, and I was like, oh, that's nasty. So really, you know, you're not going to ever have a clean wound, so we want to carry some sort of antibiotic to prevent that. The one right now, or I think the guidelines recently, but ertapenem was a very common one that we were carrying our in-vans for antibiotic prevention. Moxifloxacin is another one for like minor wounds that was being carried as well. And some of that might change, so always check with your most up-to-date guidelines. And then we move into our casualty evacuation. So this is going to, important. Somebody sends a medevac. Hopefully it's not you. Before we evacuate them, we need to make sure we've done our primary, secondary survey. We've addressed all their injuries. If we have time, we want to splint any sort of fractures. We want to apply any dressings or any interventions that may be needed. And then one of the important things here is we need to relate all that information to whoever is going to be, whoever we're going to transfer their care to, so whether that's the flight medic. So we won't get too in-depth, but like packaging patients is like an art form that hopefully you guys learn. But you want to make sure when you're evacuating them, they can access all of those interventions. So what I like to do is after they're wrapped up, cut little slits and put some white tape there wherever you have an intervention so that they're still covered. But it's kind of, if you have time, it's labeled. The flight medic will know, because it's very hard to hear each other when they're picking up patients because it's loud. But you want to make sure you're relating all those interventions that you have on those patients, so they can have it documented and they can take care of them on the flight. And then, we have special situations, so burns. Did we talk about lieutenants? That's surgery, or we'll talk about it during our burn lectures. You have mass casualty situations, which are always something to consider in triage, which we'll talk about in a sec. CPR, the current recommendation is like, you're probably not going to have great success with CPR on the battlefield, especially if they've lost a lot of blood or they're hypovolemic and you're not replacing it, so not a lot of great success rates. So they recommend those patients as expected, not to waste your time. You know, I say that, but it's hard when it's like your buddy or whatever, so do whatever you can afford during that situation, if it permits. Burns, I like that. Stop the burning, yes, take them out of the burning place, but you know, burn patients are always trauma patients first. So what caused the burn? Usually in combat, some sort of blast injury likely is causing the burn. So we want to make sure we're addressing those considerations first. However, airway is, you know, at the top of that March algorithm, so you know, that's going to be our biggest concern, is protecting that airway in these burn patients, especially with facial burns, inhalation injuries. And then keeping them warm, preventing hypothermia burns is important, and also fluid resuscitation is important, but not something you're able to usually perform in the appropriate manner on the battlefield. And then there's our rule of tens. So it's usually, you know, pretty easy calculation. There's probably a rule of 10 question on the test. I'm trying to remember, but there's definitely one on your surgery test. So just so you guys know, it's simple. So anybody that's 40 to 80 kilograms, you know, you do 10 milliliters times their total body surface area burn per hour. And then for every 10 kigs over 80, you add another 100 milliliters. So pretty simple formula. They're 40% burn, you know, and they're 80 kilograms. That's going to be 400 if they're 90, 500. And then we want to monitor urine output, which is very difficult, you know, in a tactical environment. But if we have the ability in a Foley, we're looking at like 30 to 50 cc's an hour. And then our mass casualty situations. So like it says, mass casualties and, you know, needs of casualties exceed available resources. So sometimes it's like you and a medic, and 2 patients or 2 casualties is going to be a mass cal for you. So it's all going to be situation dependent. But what's important is how we triage these patients and decide who needs the most immediate care first. So we usually use the mnemonic IDME, or it goes immediate casualties, delayed, minimal, and expected. And we'll talk about which ones fit into that category. So immediate, this is going to be immediate, like they require immediate intervention right now. So this is going to be, you know, your amputees, tension pneumothorax, somebody who, if we don't treat them within the next hour, they're likely going to die. So these are going to be your highest triage priority when you're triaging these patients. And then you have your delayed, so they'll likely require surgical intervention, but their condition is stable right now. So we can provide minimal intervention without endangering their life, limb, or eyesight. So this would be, you know, sometimes you can go from immediate to delayed if you place a tourniquet on there, but we won't get too in depth in that. Then you have your minimal, so these are going to be walking wounded, minor injuries. These ones can be difficult because a lot of times they're still walking and thinking they need treatment. So what's important about triaging is having a triage area separated with different categories so that you don't have the walking wounded interfering with your immediate casualties. Then we have our expectants. So these are people who are likely expected to die. So massive head trauma, brain matter exposed, you know, somebody with, you know, multiple, somebody who's hypotensive with, you know, multiple amputations that you don't think you have enough blood or products to resuscitate, might fall into expectant. And then here's one of our methodologies. So, you know, are they talking? Are they moving air? If not, open the airway, assess their breathing. If they're not breathing, then they're going to be expectant. You're looking at their, moving on to the B, it's going to be breathing. What's their respiratory rate? Do they have, you know, appropriate respirations? They would be immediate if they need some sort of, like, they have a tension pneumothorax and you need to put a needle in there. We would place those as immediate. If it's no, then we would move on to circulation. So if they have a radial pulse, is they, you know, do I think it's 80 over palp? What's their heart rate? If you know, we don't have a radial pulse, we need to assess, you know, whether they have a carotid or whether that patient is still maintaining at that point. And if not, we need to do something immediately. And then if it's no, assess mental status. And then if the patient's talking and responding, you know, hopefully not immediate, as long as you don't have any of those other injuries from your ABC. And then if it's a no, then you can immediately address that cause. All right, CPR, I kind of said it earlier, so, you know, if you have enough support to provide CPR and resuscitate that patient, you know, you can, but typically no CPR under care under fire. And then joint international operations, so it's something to consider. Everybody uses their own terminology, languages, so just be aware of your surroundings in the battlefield and those kind of boring stuff. All right, what questions you guys have? Nothing? Any complaints?